Good morning, everyone. Let me start by saying that the adoption of MIS AWR procedures is quite unlike anything we've seen for a while. The combination of a benign pathology with the novelty of a fancy technique has promoted the rapid development and adoption of several procedures all across the world. And while all procedures have complications which are often discussed to death, sometimes at meetings like this, here are a few reasons why we need to pay closer attention to all of these surgeries and their eventual outcomes. While there is some overlap, several complications following AWR procedures are distinct from the prevalent MIS ventral hernia repair at this time, which is the lap IPOM. Now, this is particularly important for someone who's doing IPOMs right now, but is looking to transition to one of these newer procedures. MIS repairs aim to recreate the open surgical counterparts. The structures divided, spaces combined, and even the mesh is placed, they are all the same. But the steps to get there are often very different. So even though the complications I discussed here are essentially the same as in open repairs, we are creating them in brand new ways. If you think about a complication as a destination, we are taking different routes. However, MIS repairs may yet have a greater probability of iatrogenic injury than in open surgery. So we are definitely raising the stakes. I am Eham Arora, and I come to you from Grand Medical College and Sir JJ Group of Hospitals in Mumbai. Let's begin. For the sake of brevity, I'm going to restrict the discussion primarily to MIS retromuscular or sublate repairs because these are the most popular at present. And their open counterparts, the Reeve-Stropa and open TAR, already have a well-established track record, which is going to help us perform a comparison little later on. Now, complications after these procedures are not uncommon, but as I mentioned earlier, some can be quite unique. Linea alba injury appears to be a pretty common one at that. In an open procedure, one first dissects the two retrorectus spaces and then connects them. You can see each space has a right-angled retractor put within it. So the surgeon has identified both the post-rectus sheets, permitting their safe division cranially as well as caudally. In ETEP, however, the crossover to connect the spaces is unidirectional, meaning that the contralateral post-rectus sheet division is somewhat blind. Even though there are a few visual cues, it's quite easy to see how the step can sometimes produce linea alba division, which is quite high up in the abdomen and may not have mesh cover. You can see the contralateral rectus is just coming into view. In this next case, the surgeon, while performing the crossover, missed an injury in the linea alba before he actually hit the contralateral rectus muscle. You can see a lot of subcutaneous fat is actually peeking through at the top left of your screen. Unfortunately, in this particular case, this injury was not repaired and the mesh did not reach that high up to cover this. So that's a new hernia that's waiting to be repaired somewhere down the line. Similar injuries can also be seen in transabdominal approaches like TARM. In this clip, there's a distinct linea alba disruption proximal to the hernia defect that's on your screen right about now. But the surgeon here realized the error and actually landed up closing the anterior sheath in its entirety with a barbed suture and then covering it with a mesh. You can see the needle is actually going across the iatrogenic injury right now. Another notable complication that's specific to sublate injuries is damage to the neurovascular bundles, producing denervation and atrophy of the rectus muscle. This is one of my old patients who had an ETEP with a unilateral TAR for recurrent M2W2 hernia. He came back just over a year later with some vague discomfort that we couldn't put a finger on, so we decided to scan him. And the scan showed a segmental denervation of the right rectus muscle. Now, I'm not sure how much of this discomfort can be ascribed to this, but I can't quantify any functional defect that's resulting from this complication as well. So unless I find any other reason for it, I have to think that it's a rectus atrophy that's causing the problem. Another unique complication is interparietal hernias. An inability to safeguard peritoneum or closing the posterior fascia under tension may produce postoperative dehiscence, producing an interparietal hernia where the viscera comes into direct contact with an uncoated mesh. You can actually see the post-rectus sheets on your screen just lift down like a mesh. Now, this may not be a true recurrence, but it definitely predisposes the patient to all the possible complications of one. There's pain, bowel obstruction, possible strangulation, and erosions as a result of interaction with an uncoated mesh. Now, what is alarming is that this posterior disruption is not diagnosed clinically. You need a pretty high index of suspicion and radio imaging, as you see on screen, to cinch the diagnosis. Once again, this is a known complication of the open restopa as well, but its incidence is much higher in MIS repairs. Here's a case with a very complex recurrence after dehiscence of both the anterior and posterior fascias after TAM. These two defects in the fascias are also a little offset, which produces an oblique passage of viscera across the abdominal wall. This patient, we went back in open, and Dr. Ramesh Punjani from Bombay and I, we landed up performing a bilateral TAR, and this is the patient's post-operative CT a year later. You can actually appreciate the new mesh that we've placed having this little waviness that is deeper to the rectus abdominis and the TA slightly more laterally. But by far the most disabling and challenging iatrogenic injury to repair is from a semilunar line disruption. Now, this young lady had a 4-centimeter primary umbilical hernia, which was repaired using a bilateral laparoscopic TAR, as per the operative notes. Not only did she have a retrorectus abscess around the mesh, but she also has bilateral semilunar line injuries, possibly because the operating surgeon got disoriented and landed up going far too lateral with his division. This patient has 2 large hernias, an abscess that needs some sort of management. We landed up performing an open mesh explant and will hopefully perform a definitive repair for the hernia soon. Unfortunately, this is not uncommon. Social media is full of similar images of semilunar line injuries, which can be a real challenge to fix. Now that I've discussed the weird and most dreaded complications of these surgeries, let's see what literature has to say. Most of the published series come from high volume centers with truly masterful surgeons. They report very reasonable and sometimes enviable complication rates. But these good outcomes can't always be replicated in a real world scenario by a different surgical team, often in a different part of the world altogether. Let's start with a comparison of open and robotars. These are the studies I'm going to be referencing, and you'll notice some familiar and pretty big names in there. So by and large, the operative times are longer in robotar, but the greater investment of time and effort pays dividends in the form of reduced length of stay. There's no difference in SSI risk, but seromas are definitely more common in the robotic approach, possibly because the ab wall and the hernia sac aren't debrided in open cases, as is the norm in open repairs. This has prompted some to explore the impact of hybrid procedures involving the robo and comparing them with purely open repairs. These researchers found that the operative times are still shorter for open TAR, which makes me wonder if maybe we could invent a robot that can dock the robot faster than a human. Jokes aside, the length of stay for open repairs remains long. The real challenge in hybrid repairs, or the real change, is actually the drop in SSOs. In one of the studies, their incidence was the same as in open repairs, while in Abdu's paper, it was actually much lower, possibly because they landed up excising the excess hernia sac in the open part of their hybrid surgery. This is one paper that I particularly like. It's a more expansive look at the long-term outcomes after open and robotic retromuscular repairs. These researchers found that the quality of life scores improved similarly from pre-op levels between the two groups. There was no difference. Wound morbidity and recurrence risk were also similar. The two groups differed primarily in their length of hospital stay, which makes me feel like eventually the choice between procedures is going to come down to patient pathology characteristics as well as cost effectiveness. Let's take a step back and take a look at SSIs and SSOs. These definitions are pretty broad and very inclusive, which makes it difficult to interpret the numbers. How were any of these events diagnosed? Were the seromas picked up clinically or on imaging? Did they have standard protocols for imaging in the post-operative period? Did the patient even complain about the seroma? What fraction of the seromas and infections actually had an impact on the patient? We don't really know because the prevalent definitions are rather sterile. Excuse the pun. They are great for reporting incidents, but they don't divulge much information about clinical relevance. For example, the image to your left, here's a patient with a small palpable seroma from a lateral hernia that's not causing discomfort, but it's definitely palpable. Here's another seroma in the retrorectus space following an ETEP TAR, which is incidentally seen on a follow-up scan. The patient doesn't have any issues. This, on the other hand, is a large infected seroma with overlying bone cellulitis that definitely warrants attention. But there's no good way at present to convey all of the relevant information. Let's also take a look at the comparative studies that I mentioned earlier. Almost all of them universally mention SSIs, SSOs, and SSOPI rates, along with recurrence, which is a norm when reporting hernia outcomes. These numbers are low, in line with other ventral hernia repairs, but the complications specific to these AWR surgeries find really scarce mention in these papers. In stark contrast, social media platforms are flush with surgeons discussing their own complications or seeking help to manage someone else's. Here is another set of large series of cases from all over the world, including my part of the world, where the reporting patterns kind of repeat themselves. It looks like complications are often underreported, and there exists a clear publication bias where favorable outcomes are reported more often than the real world adverse events. And truly, it seems like the high volume centers are publishing way more than the low to mid tier centers. At this point, I won't go so far as to say that the data is inaccurate. Rather, sometimes it just appears incomplete. Now, I don't want to be a mindless wet blanket and smother the adoption of good surgery, but maybe, just maybe, we need to curb our collective enthusiasm. Each conference has at least one speaker show the Dunning-Kruger curve, and I'm quite happy to be the first one to do so today because it's still early in the schedule. The Dunning-Kruger curve shows that we start off with a lot of enthusiasm and confidence, and we feel like we know everything. But as we notch up the numbers, we realize there's a lot more that we don't completely understand, and true mastery is achieved as a function of time and effort. Where do you think we are as a surgical community with regards to these new procedures on the curve that you see on screen? In my mind, there's two ways this story plays out. One would be similar to that of lap and robotic Whipples, where initially centers all over the world adopted the procedure, had some really encouraging reports, and people started performing minimally invasive Whipples more and more. But not all centers could replicate the great outcomes. This then prompted the development of guidelines for who should be performing these surgeries. It was based on annual volumes and the breadth of their advanced laparoscopic as well as open surgical experience. The other possibility, and one that I am personally more optimistic about, is that this plays out like lap cholecystectomy, where we had quite a few iatrogenic injuries soon after the surgery was developed, but thankfully they've now significantly trailed off. I'll leave you with one thought. Of successes several integers, self-awareness is often overlooked, yet can be most important. I'd like to thank you all for your time. And I'd especially like to thank the organizing team for inviting me to speak at this great event. And I'm really looking forward to the rest of the meeting.
Thank you. Well, I want to congratulate all the speakers who have given us food for thought. Whilst we're waiting for some questions from the audience, I'm going to throw one firstly to Eham, and the others can jump in as well. So you alluded to the fact that perhaps the data is not as robust as it might be. So I've always wondered whether we get an underreporting of complications or perhaps an overreporting of complications when we get them from centres of excellence, because they're people doing the work all the time, and therefore you might expect their complication rates to be a bit lower. Or are they more fastidious and pinicky and they pick up all the tiny complications that might not otherwise really be an important thing? I'm wondering what others have to think about that, and whether or not we really know what the complications are.
That's a great question. Regarding the smaller complications that are relatively infrequent, I think it's difficult to convey all of that information within a paper. You want it to be concise and dense, and you want to get some points across, but discussing individual patients with an odd complication a little too much may be a bit distracting. I honestly do feel that the centers of excellence are not having these complications as often as, say, lone or small surgical teams out there in the world. But also, it also comes down to the definitions. So a lot of these patients who are coming back with bulges and hernias, they're going to be labeled as a recurrence. But somebody has to look at the operative videos a little closely and figure out, was this recurrence just a function of the mesh not having great overlap, or was it actually because of iatrogenic facial injury? Because these complications you don't see in the other forms of hernia repairs. These are relatively constrained to the newer AWR procedures that we're seeing right now. So I think we need to be more honest as to what's happening in the OR and not be quick to dismiss these recurrences as just routine parts of the surgery.